Okay, so we're moving on to more. This is our fourth mini lecture about TB. I'm going to talk about the rise of drug resistance and HIV-TB co-infections this time. Tuberculosis is curable and preventable. If you are run down or have a cough, get a medical examination. Seeing if my mic's falling off, but thankfully it's not. You can see that this is an old billboard in the United States. And it was produced by the Maritime Tuberculosis Educational Committee. So drug-resistant TB is classified as M. tuberculosis organisms that are resistant to at least one first-line treatment, including isoniazid, rifampin, pyrazinamide, ethambutol. I always have such a terrible time pronouncing these things. Primary resistance is caused by person-to-person transmission of drug-resistant organisms. So I have it, and I transmit it to you. Secondary resistance develops during TB treatment. Patient was not given appropriate treatment regimen, or the patient had adherence problems to that particular regimen. So, of course, when you're given antibiotic treatment, you should always finish your course to avoid developing resistance. And this is a serious problem in developing countries, obviously. Monoresistance means it's resistant to any single TB drug. Polyresistance means it's resistant to two or more TB drugs. Multi-drug resistant to at least isoniazid and rifampin, the two best first-line TB treatment drugs, and extensively drug resistant to isoniazid, rifampin, plus resistant to fluoroquinolone and at least one of 3 injectable second-line drugs. So when we talk about multi-drug resistance, we're talking about a lot of things. And obviously we can get to the point where nothing is effective against TB, and then we're in real trouble, obviously. MDR-TB, 3 countries account for 47% of cases: India, China, and the Russian Federation. U.S. had 9,000 cases of TB, and 600 of those were isoniazid resistance, 123 were multi-drug resistant, and 2 were extremely drug resistant. Drug resistant and TB treatment options. Interim results for this trial were moderately successful. 75 cases were cleared. XDR impacts transmission of extensively drug-resistant tuberculosis is a major concern, and occurred in South Africa, according to this paper. 404 participants. Out of that, 311 had HIV infections, and a total of 280 participants had never received treatment for MDR tuberculosis. Clusters ranged from 2 to 14 participants. So this is a sort of rudimentary network contact tracing, network analysis. You can see that some of these clusters have crossover between each other. Drug-resistant tuberculosis transmission is a major concern, and it should be for everyone. WHO Roadmap 2017. First, prevent the development of drug resistance through high-quality treatment. Obviously, we want to stop these if we can. Expand rapid testing and detection of drug-resistant TB cases. We want to find them if we can, and provide immediate access to effective treatment and proper care. And this includes health system strengthening. We always want to prevent, and of course, we want to increase political commitment with financing. HIV, TB are co-epidemics. The direct contribution of HIV to multi-drug resistant TB is not clear. HIV co-infection does not appear to directly influence mutation rates of M. tuberculosis in patients, but HIV has fed the TB epidemic and co-circulation in marginalized populations. And clearly, the more cases of TB you have, the more risk for multi-drug resistant TB you will have. HIV, TB is shifting global burdens. You can see here, HIV deaths are going down. TB deaths in HIV negative people went up in the mid-2000s. And TB deaths in HIV positive people have sort of remained somewhat flat. going down, but not as quick as HIV deaths overall, or TB deaths in HIV negative people. In an HIV infected person, TB can develop in one of two ways. Persons with latent TB become infected with HIV and then develop TB disease as the immune system is weakened. So they're already infected and their immune system weakens and it turns into symptomatic TB. A person with HIV infection becomes infected after becoming infected with HIV and then rapidly develops TB disease. So there's really two sort of pathways that people can follow here. People infected with both M. tuberculosis and HIV are more likely to develop TB disease. Remember we talked about the difference between infection and disease. TB infections and HIV infections, risk is about 7 to 10% per year, a very high risk over the lifetime. Co-impacts. Progression of HIV is accelerated in the presence of TB. Risk of latent TB developing into TB is 20 times higher if a person is HIV positive. Latent TB also rapidly progresses if a person is HIV positive, so they're more likely to develop disease, and their disease progression is much faster. Treatment options become very, very challenging, as you can imagine. Sequence of diagnosis, initiation of treatments can impact outcomes. More advanced HIV at TB diagnosis leads to very poor outcomes. Realities of the co-epidemic. There's a paper here from Brazil, and there's a final model of the risk factors for defaulting from TB treatment among HIV subjects in the state of Pernambuco. HIV positive people in some at-risk populations have poor adherence to treatment regimens and then are more likely to move on to advanced TB. So that's it. Hope you've enjoyed this short discussion of TB. And if you have any questions, please reach out because I'm here to help you.